In my
This
home in
conference
Sun
will now
Lakes.
be recorded.
In Sun Lakes. Okay, welcome. And are you a
Okay,
caregiver of someone with ALS, or do you have ALS?
I have ALS.
You have ALS. Okay.
I think we spoke sometime in the past when I was looking to get other information.
Well, we probably did. And since you're signing, it seems like you have some information.
I'm gonna break your phone.
Here we go. What do we got going on here?
Hold on.
Uh-oh.
Well, I see the Doucettes have joined us as well. Dave, I'm going to mute you.
Okay,
I miss seeing people in person. I'm over COVID. I don't know if anybody else is feeling the same way, but I'm over this. I mean, I realize it's not over and we can't give up and those things, but I'm ready to be done with it. Unfortunately, I don't think that's happening anytime right away, but it drastically impacts all of us. Yes, Marie and Cliff, I'm still here. I see you're still here or back again. And Betty Ann is joining us again or still from Scottsdale. So welcome. Welcome to all of you guys. We've got people logging on, so we're going to wait just a minute here. I don't even know what time it is. Right at 2:01. And Janie, you hit record for us, right?
For once.
I guess you're not a presenter right now because my screen is sharing. So I'll make you the presenter after we get through these slides and the Maxim commercial.
Okay, that'll be fine.
Okay. Sue, we appreciate you joining and being on. And I have a picture of you that's going to pop up on the slide. And so I know that's going to stress you out, but don't get stressed when I tell them how wonderful you are, okay? Oh, I see Dagmar. Hi, I haven't seen you in months. How are you, dear? You look gorgeous as always. Good, I'm glad you're doing well. Okay, we're gonna go ahead and get started. It looks like we've got some people signing on to this session who have not previously signed on earlier today, so I'm gonna go through the whole rigmarole. For those of you who've heard it again, you can mute me for a few seconds if you want. It's like the airplane, we have to do it all the same, even though you know it's all, you already know it and you're ignoring them anyway, but it has to be done. So welcome, my name is Amy. I'm the Director of Care Services for the Arizona chapter of the association. I've been with the chapter 5.5 years. And I am so excited to see this many people in the Caregiver Skills Workshop. I am gonna go ahead and give you a disclaimer right now that this is a session, Caregiver Skills is something we usually do live and in person and hands-on, and that's the way we want it to be. We're doing the best we can right now. We want to still offer something, even though it can't be as in person. This session is potentially, I can probably guarantee it's going to be a more choppy and a little more confusing, not confusing, but hard to hear and deal with, because we're going to go back and forth between videos and conversations. So please just be patient through that. But the point of this is interactive. So you should be asking questions. You should be saying, wait, how did that look? And where did this go? And things like that. So please be patient through that sort of stuff. But we want and need for you to engage, because this is your opportunity to learn how to do this and to practice it. So please don't hesitate on that. We have everybody on mute now. Please leave yourself muted unless you have a question, but I'm pretty sure that Janie and the team is gonna stop and ask for questions throughout, not just all at the end. But you're welcome to also type your messages in the chat box, and we'll be monitoring and answering those questions as well. So if it's easier for you to ask questions live, you can unmute yourself and ask a question. And if you're able to put it in the chat box, then Amanda will be sure to get to those as well. We are recording this session. We will send out a follow-up email in a couple days that will have a link to the handouts that are going to be discussed here, as well as an evaluation form of the entire day's conference, as well as the link for this recording here. So before we get started, we're going to take a minute to thank our sponsors: Bayada Healthcare, Quantum Rehab, Maxim Healthcare, Ability Center, Permobile Foundation, Motion Foundation. I'm trying to, sorry, New Motion Foundation, United Access, and we're going to view a brief message from another one of our sponsors, Maxim Healthcare. So I'm going to go ahead and get that playing now, and we'll be good to go. So, oh my goodness, no, I'm not, because I forgot.
Maxim Healthcare Services is
Can you hear that?
making sure your family is cared for, staying late to keep everything clean, taking additional precautions to keep you safe, and doing what it takes to keep our patients happy and healthy in their homes. We are committed to our families and our communities. We are here for you today, every day, and when it matters most, providing the same great care with extra protection.
So as I said, Maxim is another one of our providers, and we very much appreciate all that they do to provide care for the families they work with, as well as for our association. Okay, now we're going to move on to welcoming our presenters. Amanda Canizales has been a registered nurse for over 8 years and has worked with ALS patients for the past 4 years. She finds great joy in volunteering with the association and the Arizona chapter, and we call on her on a regular basis. So we appreciate all that you do, Amanda. Thank you. Janie Dalrymple has been a registered nurse for over 16 years, and she's been the nurse educator with our chapter here for the last 2 years. She's board certified patient advocate and end-of-life doula, as well as an elder care consultant, and is the owner of Your Patient's Advocate, an independent patient advocacy business helping clients navigate the healthcare system and end-of-life issues. And Sue Melland, did I say that right, Sue? Yeah, okay. Is a physical therapist at the Mayo Clinic in Arizona. She received her Bachelor of Science in Physical Therapy from the University of North Dakota and received her doctorate in physical therapy from A.T. Still University in Mesa. She's an instructor at the Mayo Clinic College of Medicine. In her current role, she provides physical therapy to an outpatient setting, primarily to adult patients. In addition to patient care for musculoskeletal and neuromuscular conditions, it's hard to say all that, Dr. Mellon provides wheelchair seating and mobility evaluations and is a team member of the weekly ALS clinic team on the Scottsdale campus, evaluating and advising PALs regarding physical therapy concerns. Sue has also enjoyed participating in local ALS events, previous caregiver training sessions, and provided education to caregivers regarding mobility concerns. Once again, Sue is always willing to jump in and help, and this is the team that we call on every time we need help. George, it sounds like you may be stuck in a loop, so if you want to log out and log back in, it may fix that. Unless, is anybody, Janie, can you guys hear me okay? Are you having issues? No, okay. Yeah, I heard what you were saying, so it sounds like that. So with Janie and Amanda and Sue, you guys are definitely in good hands for the next couple hours, and they are going to get you guys all set up and answer questions and things like that. So Janie, I'm making you the presenter. So you can share your screen with us.
Thank you very much. Okay. Well, I guess first, before I share my screen, I just want to say this is obviously the first time we're doing this virtually, so please bear with us, number one. We have in the past had our Caregiver Skills Day where clearly our caregivers are coming in and we are doing hands-on training with the equipment, and we are making you use the equipment so that you feel comfortable with it when we bring it out to your homes. So we tossed around the idea of how are we actually going to do this. And there is another ALS chapter that had some very, very, very good doctorate students, physical therapy, doctoral students who did this for their capstone project for the ALS Association of the New Hampshire chapter. Was it, Amy? I think
Northern New England.
Northern New England, sorry.
The school's in New Hampshire. I think it encompasses a couple places, but it's the Northern New England chapter.
Yes. So they have recorded videos of using most of the equipment that we use for our patients, and they have done a very good job with it. So that's how we're going to proceed right now. We're going to show you 2 videos. I think the first one is 6 minutes and the second one is 9 minutes. They go very quickly. So please watch them, take down some notes if you have questions about it. And at the end of each video, we'll let you ask some questions if you have any about using these pieces of equipment, doing the transfers, that sort of thing. And then after we're done with each of those videos, we're going to move into doing showing you how to do some range of motion exercises, and then we'll get into some more stuff. But for the first part here is going to be 2 videos. So I'd like for you to refrain from asking questions until the first video is over with, because it goes pretty quickly, and then we can go from there. Hi, Dawn. I see you just joined. If you can mute yourself, that would be fantastic.
Okay, why isn't it muting?
Welcome to the ALS Care for the Caregiver's first video recording. This episode will cover body mechanics, putting on a gait belt, as well as transfers from supine and sitting at the edge of the bed.
Can you guys hear it?
With and without pivot discs. Please note that the information and demonstrations being provided in this recording are designed for general educational purposes only. This recording is not a substitute for medical advice. Each caregiver and/or patient should be seeking the guidance from their personal physician and/or a personal healthcare team regarding which devices or transfer techniques are safest for them.
Janie, is there supposed to be sound with this? Because we can't hear now. We could hear the opening and now there's no sound.
Yes, there's supposed to be sound.
Try it again and see if they can hear it now. No, because that's muted. So play it again because we were on mute.
To apply the gait belt, your loved one should
Can
be
you
in a
hear it?
When your loved one is laying on their back
Yes.
as shown,
We
apply
can
the
hear it
gait belt
now.
through the waist and thread the gait belt through the teeth of the buckle. Make sure the gait belt is in their midsection, but not too tight where it's hurting them, or not too loose where the gait belt is sliding up and down their waist. About 2 fingers should fit in between the gait belt and their waist. Lastly, slide the belt through the loop to secure it and tuck away the excess under the belt.
The next transfer we'll be doing is a supine to sit transfer.
Janie, you may want to stop at the screen in between, and I don't know.
What's that, Amy?
I was saying you may want to stop at like in between when the screen switches to another one. I guess go all the way through and we'll see, but we may need to go back and like replay those parts again for people.
Okay.
As we're turning to the right side, if their foot is flat on the bed, have them reach with their left hand to the right for the edge of the bed. Place your hands on their left hip and their left shoulder, or you can put it on their left knee. Ask your loved one to push off with their leg and pull with their left arm at the same time as you help them move as a unit to position them on their right side. Make sure your loved one's right arm is not under them and won't get pinched. You may need to move their arm if needed. Assist the loved one by lowering both legs off of the bed. Have them do as much as possible. As the legs are lowering, ask them to walk themselves up with their arms. Here you'll see that same transfer from a different angle. We will now be performing a squat pivot transfer. To begin, place the wheelchair on a 90-degree angle to the bed, and you can either choose or choose to not take off the armrest closest to the bed. Be sure the wheelchair brakes are locked before beginning the transfer. As a caregiver, be sure to communicate with the patient to make sure that you're on the same page with the task that will be performed. Ask your loved one sitting at the edge of the bed to scoot forward enough so their feet can be flat on the ground. Next, have your loved one place their foot closest to the wheelchair, slightly out in front of the foot farther from the wheelchair. The foot farthest from the wheelchair should be tucked slightly underneath the bed. As a caregiver, place your feet hip-width apart, slightly staggered, and get in a good squat position. Keep your loved one close by having them lean forward. Grab the sides of the gait belt or the pants of your loved one and stay in a good squat position. Count to 3 out loud, and on the count of 3, assist your loved one up and over to the wheelchair while you both have your knees bent. Sit them down slowly and in a controlled manner in the wheelchair and place the armrest back on the wheelchair and unlock the wheelchair, ready to go. We will now watch the squat pivot transfer from a slightly different angle. The next transfer we will show is a
Okay, I'm gonna stop it right there just so that since they're going so fast, does anybody have any questions up until this point?
Actually, I do. My husband cannot use his hands or arms, almost nothing. So on one of those examples, you know, they had them holding onto the edge of the bed so you could roll them off. That's not really going to work because he can't hold on. What am I supposed to do then?
That's right. We will be showing you transfers with a Hoyer lift and other lifts for patients that are completely dependent.
Well, his legs are perfectly fine. It's only his hands and arms that are almost unusable.
Okay.
So, okay.
Sometimes you just have to be tucking those arms like in so that you can even tuck the arms into the gait belt just so that the arms don't drag behind them. And then that way you're going to use more of your body to kind of pull them up with the shoulder, even if they can't use them. But you just want to be sure that they're not dangling down if they can't use their arms very well. And if you cross them, you can kind of get your arms to hold their arms in so that they don't come out too. But that would be something that would be really easy to practice, like with a, you know, with a home health nurse or a PT visit, so that you could kind of get the feel for it. Because you're right, you don't want those arms to get caught and they can't help you at all. So you need a little more body support from yourself.
Yeah, he doesn't need a wheelchair, but he, you know, he does need help out of the bed. So.
And Amy brings up a really good point that these videos are wonderful. They did a great job. But one of the things that some of the things you're going to see in this video will not apply to people with ALS. So the videos that they were making don't necessarily, like you said, not everyone can scoot to the edge of the bed. As in one of the videos, he said, have them scoot towards you. Or they're going to say, you know, have the person that you're transferring help. And those are things that why we're going to stop and talk through them for this exact question, because it's not that easy when they're not able to help.
Is there another approach to the squat and bend for the caregiver? Because I've got 2 knee replacements and I thought, I don't think I could get that bend at all.
Yeah, well, what we would recommend then probably would you would just be closer to them, and that you would maybe utilize one of the next things that they have, like a that was excellent.
I have a question. Right now, my caregiver is my wife. While I don't need her help often, sometimes I do. She's a petite woman. She weighs 103 pounds. I weigh 155 pounds. Is this something that she would be able to do?
I would say it's going to depend on the proper bottom. Am I echoing really bad?
There
it goes, better.
I'm trying to mute people so that you're not. Go ahead.
So yes, you can move a heavier person than you are. You can do that. It takes a little practice in learning how to shift your body weight forward and backwards, but with the help of the gait belt, yes, it is possible. It sort of depends on how much trunk control you have as well. So that would be one of the things that, again, we would probably want you to practice with some professional so that they could tell you whether or not your caregiver would be at risk, because that's always a concern. We don't want anyone to get hurt doing that. And then we would talk about alternative ways to do it. But it is possible to lift someone heavier than you if you use the right mechanics.
Thank you.
And I want you guys to keep in mind too that these videos that we're showing you are transfer and moving techniques that professionals need to teach you. We're not intending for you to watch this video and go home and figure it out yourself. We're doing this because this is a virtual realm that we have to use right now because we can't be together. But if you feel like these are things that you need to start taking advantage of now, these ways to learn, these techniques to use, that you should be discussing with your clinic team so that your doctor can order some home physical therapy, or if you can even do outpatient physical therapy, that the patient is then going in and being educated by a physical therapist or an occupational therapist. So these are not meant for you to watch one time or go to YouTube and figure it out on your own. We are simply showing you this because we can't bring you into that physical realm altogether right now to do it like we would. But this is something that the doctor can order for you, and physical therapy can show you how to do these. So just keep that in mind. We're not doing this as meaning for you to learn on your own. So
if I may, I will just say that I think that there certainly is a relationship between the weight of the individual being cared for and the strength of the caregiver that's trying to provide the help. And the relationship between those two factors certainly makes a difference in being able to efficiently move some individual, the weight and the strength of the individual trying to move the person.
yes, you're very correct in that. And one of the things that we want to teach caregivers as well is good body mechanics and also the right tools to be able to move someone safely, both for the caregiver and the patient. Both people have to be safe in that transfer. Sometimes those transfers aren't going to work with a very small caregiver and a very large patient, no matter the best body mechanics that we use. But we want to try to set you up with the best possible tools so that you can do that if possible. That's for sure.
I think we all certainly want to try and be a caregiver as a loved one, but in some instances that might not be possible, that you would have to have outside caregivers and help.
Right, exactly.
A lot of situations.
Right. Okay, let's move on to the next video.
Squat pivot with the pivot disc. This transfer is set up exactly as a traditional squat pivot transfer setup. However, instead of staggering your loved one's feet, place both feet directly next to each other on the pivot disc. The pivot disc is used to help assist the lower extremity with the transfer. Count to 3 out loud and help to transfer your loved one to the wheelchair as you would with a traditional squat pivot transfer. Be sure to communicate with your loved one accordingly. And if they end up too far forward in the chair, have them use their upper extremity if possible to push back.
This is a stand pivot transfer. Approach your loved one in front of them. Make sure they are sitting near the wheelchair. Have them scoot forward on the bed so just their buttons on the bed. You position their foot near the wheelchair to stagger slightly ahead of the other foot, like shown, with both feet flat on the floor. Grab the outside of the gate belt with your palms facing their body. Make sure to straighten your back and bend your knees to prepare for the transfer. Tell them you are going to have them lean slightly forward at their trunk. On the count of 3, they are going to push with the heels of their feet as much as they can while you assist them to a standing position. When standing up, they will turn their feet toward the wheelchair with their back to the wheelchair, and their thighs touching the wheelchair seat. Have them sit down slowly while you assist them to a seated position.
So just so you know, those pivot discs that you just saw there, we do have some of those in the office. They are meant to be able to move feet when feet are not being able to be moved by themselves. So if you are interested in getting one of those pivot discs at home, you can get a hold of me, Amy, one of the girls in the office, and we can get those sent out to you. Does anybody have questions about that pivot disc? Okay, let's keep going.
This is a stand pivot transfer with the pivot disc. Approach your loved one from the front and place the pivot disc on the floor, a foot from the edge of the bed.
Maybe we're getting it again,
Make sure the
sorry.
wheelchair near the bed is locked. Place both of their feet on the pivot disc with their feet flat and toes pointed forward like shown. Grab the outside of the gate belt with their palms facing their body. Have your loved one scoot forward on the edge of the bed. Tell them that you are going to have them lean slightly forward at their trunk. On the count of 3, they are going to push through the heels of their feet as much as they can while you assist them to a standing position. When standing up, the caregiver will rotate their loved one toward the wheelchair and slowly lower them to a seated position.
Same thing. Okay.
Hello again, and welcome to episode 2 of the ALS Caregivers Workshop. This week, we'll be going over a sit-to-stand transfer using an automatic sit-to-stand machine while transferring your loved one into a wheelchair. We will also demonstrate a slide board transfer from the bed to the wheelchair, as well as from the wheelchair to the bed. Please read the disclaimer posted carefully before attempting these transfers with your loved one.
To turn on the automatic sit-to-stand, begin by turning the knob at the top of the machine. The knob should pop up and the machine should light up. This indicates that it is turned on and ready to use. To apply the safety belt, put the belt under your loved one's underarms and secure the buckle in the front. Tighten or loosen the belt if needed. The belt should fit snug around them. Next, move the sit-to-stand in front of your loved one. Make sure you lock both of the brakes. Have your loved one place their feet on the platform. Next, place the loop straps onto the hooked portion of the sit-to-stand. Have your loved one place their hands on the outside of the sit-to-stand and hold on. Grab the remote and hold down on the up arrow. The machine will begin to rise. Instruct your loved one to keep their feet on the platform and hands on the machine. You may place your hand on the loved one's back as shown for added support, but it is not necessary. Continue to hold down the up button until the machine stops moving. Once the machine has stopped, you may now unlock the brakes and move your loved one to the desired location. Once at your desired location, you can now swivel the handle at the front of the machine to widen the back wheels to allow for the machine to get as close as possible to the transferring platform. Make sure you relock the brakes. You may now press down on the down button on the remote to lower your loved one. Once the machine stops lowering, you may now undo the loop straps and unbuckle the safety belt and remove it. The transfer is now complete.
Okay, so this specific piece of equipment we do have in our loan closet. Someone did just ask, what if there's no arm capability? Clearly you want this on someone that is still able to use their arms. And typically this is on someone who still is able to bear weight on their legs, but not necessarily able to take any useful steps. So it is helping with that movement, but if they were not able to bear weight on their legs, this machine is not going to support them. So I don't know, Sue, if you want to say anything else about this device. A lot of our ALS patients do not use this piece of equipment because they don't necessarily need it a lot. We don't have a lot of people that would use this. We typically go to a Hoyer lift, but we do have these in the loan closet, and some patients do like this when they are still able to get enough strength in their legs to at least bear weight on their legs, even if they aren't taking useful steps. So would you agree, Sue?
Correct. Yeah, you have to have upper extremity strength. Your arms have to be strong enough to hang on, and it is usually something that they would still benefit from a Hoyer for a longer period of time. So
yeah,
it's not used very often.
Right. So we do have these, like I said, in the loan closet, but typically they are not used very often. Patients usually will prefer to use a Hoyer, and you will see that moving forward. And then somebody also asked, what are the specifics to look for with a gait belt? They Googled and said that there's a huge range. Sue, you want to give a go-to on how to pick out a gait belt?
Basically, the most important thing is just size, and they give you usually a waist size. So if it's way too big, you just end up with too much strap, so that won't help. But as long as it's a mesh belt, they're usually pretty uniform. There are some that have handles on them, which are really wonderful, but if especially so you don't have to dig into your fingers into the backside of them, but they're more expensive and they're not necessary. So the basic one we usually actually will give you if you they have some of them available, but I would basically, the most important thing would be the size.
And I will put in my email address in the chat box. If any of you want a gait belt, we have those in the office. So actually, Amanda's putting that in the chat box right now. Just email me and we will send you guys out a gait belt so that you know how to do that. So, okay, we're gonna go on with the next video.
Can I say one more thing quick? The thing is, it's really important to use a gait belt to save the caregiver's work. It's much easier to have a gait belt. It seems like it's a lot of a hassle to put it on and off, but it's much safer, and there are way less accidents of people slipping too much or not being able to hang on to them. So I really do recommend them. And then the other thing is if you do have like someone that's got some tube feeding, you have to talk about the placement for that. You want to be sure that you don't put it too low so it's going to slip up over that. It would have to be a little bit higher. And again, there's some options of other places even using it underneath them to kind of help boost them up from the bum. And that would be something you would practice with a caregiver or with a professional.
Thank you.
This is a slide board transfer from the bed to wheelchair. With your loved one in a seated position on the edge of the bed, bring the slide board over to the bed. Position the wheelchair so it is on a slight angle rotated towards the bed like shown. Take the armrest off of the wheelchair that is closest to the bed and place it down in a spot near the bed, but not on the bed. You'll need it to place it back in the wheelchair later. Make sure the space between the wheelchair and your loved one is clear. Now it is time to place the slide board in position for the transfer. If transferring your loved one to the right, tell them to lean on their right buttock while you place the slide board completely underneath their left buttock. Make sure your left arm is guarding the right side of the body as they lean. If positioned correctly, the board should be angled towards the wheelchair and floating in the air while your loved one's left buttock is sitting on part of the slide board like shown. Instruct your loved one to place one hand on the board toward the wheelchair and one hand near their other side. Before you begin transferring, instruct your loved one that they are going to push up through their hands while you assist them by using the gait belt with a scooting maneuver like shown. This maneuver should be relatively fast and very safe. You are always there to assist them as they scoot over, and they are using their arms to push their buttocks up and toward the wheelchair. This transfer will typically use 2 to 4 scoots before your loved one makes it into the wheelchair. Once in the wheelchair, have them lean on their left buttock while you are guarding them with your right arm and remove the sliding board like shown. Reposition your loved one in the wheelchair comfortably. Now place the wheelchair arm back on the wheelchair. Make sure it is locked in place. Unlock the wheelchair, and you're off. This is a slide board transfer from the wheelchair to bed. This transfer is the same transfer we just went over, but in the reverse order. Some key things to note for the slide board transfers in general. The wheelchair seat height and the height of the bed mattress should be relatively the same so that the transfer is not difficult to complete. This is because you do not want to literally have to lift your loved one up multiple inches up off the board, as this is very dangerous. Make sure your body mechanics are good while you are providing assistance throughout the transfer. Keep your knees bent and your back in a straightened position while maintaining tight, contracted abdominals and low back muscles to keep yourself safe. Before your loved one attempts to scoot over, have them brace their abdominals by tightening their stomach. Make sure that you and your loved one continue to breathe in and out throughout the transfer. Try not to hold your breath.
If you're managing a team, you have to try Monday.com. Monday.com is a platform to track everything your team is doing. We use it for all our projects: marketing, product development, HR, creative productions. I love Monday.com because it's totally customizable, and that's something I
Okay. No, close.
couldn't find in any other management tool.
Oh,
I can
sorry,
choose what-
snafus. Okay, first, does anybody have any questions about that transfer? Go ahead, Sue.
Can I just say that on that last transfer, you could see the back of that belt had a had the loops on it that we were talking about. And then the other thing is for the gentleman that before that was asking about if your patient was a lot bigger than you and you wouldn't be able to lift them up, that's one of the places where a sliding board comes into play. The other thing is it looked like he kept lifting her and moving her and lifting her and moving her. And actually the term sliding board is that you don't have to lift them, that you can actually scoot them a little bit. So it looked, because she had good strength and he did too, it is something that you can use to kind of pull them over with if you have to, just so you know that. If you don't have arm strength to be able to lift yourself up, it still works.
Yeah, and I think that I use this most effectively with ALS patients that still do have some arm strength to be able to push off with their hands and good trunk control. So if your ALS patient is leaning in their chair, if they're leaning forward, if you're propping them up with pillows and things like that, a slide board is not good for those sorts of patients. So if they're still able to maintain their trunk ability, they've still got those abdominal muscles and things like that, their legs aren't working great, but they can still use their arms, then that's a great way to transfer from bed to chair, chair to bed, that sort of thing. Especially a lot of ALS patients use that at night if they want to transfer into like the wheelchair for somebody to take them to the bathroom at night, or maybe even transferring over to a bedside commode that's right at the edge of the bed so that they're not doing a lot of fatiguing work at night and they're still able to transfer in and out of bed. So that's what that slide board is mostly used for with our ALS patients. So that's kind of what we use that for. Okay, we're gonna move to the next one if I can figure out. Yep. Next,
Welcome to the ALS Care for the Caregivers episode
well, maybe.
3. In this episode, we'll be discussing toilet transfers with the use of a sit-to-stand machine, as well as a pivot disc squat transfer, as well as a transfer to and from the tub using a squat pivot technique, and Hoyer transfers to and from a bed. Please take some time to read the following disclaimer. This is a toilet transfer with a sit-to-stand machine. With your loved one secure in the sit-to-stand machine, position them so that they are ready to assume a sitting position on the toilet. Stop when you see or feel the back of their knees come in contact with the toilet and then lock the brakes. Use the control button to lower your loved one onto the toilet as you use your arm for additional back support while moving into the seated position. Once your loved one's bottom has come into contact with the toilet and they are comfortably seated, they are able to go to the bathroom. For the purpose of this video, Michaela had her bottoms on, but ideally you would want to transfer your loved one without the pants on in order for them to go to the bathroom. As far as getting the patient from the toilet back to the standing position, it's as simple as using the controlled remote to raise a patient. You can provide additional back support using your hand as well. Once the patient is in the standing position, you can unlock the brakes and transfer your loved one to wherever they need to go.
Okay, and so I just want to let everybody know again, typically this is not a machine that our ALS patients would use. We do have it in the loan closet, but like I said, most patients are not going to use this. This was just part of the video, so it's here for informational purposes, but most times we would not use typically a sit-to-stand.
Performing a toilet transfer with a pivot disc, make sure that the gate belt of your loved one is placed securely and position the wheelchair as close as you can to the toilet. Lock the wheelchair brakes and remove both leg rests and the arm rest on the side that you are transferring to. Make sure that your loved one's feet are in firm contact with the pivot disc and communicate with them so that the transfer is safe and coordinated. Make sure your body is as close to theirs as possible to avoid any strain on the back and provide knee blocking for additional support. Have the patient lean forward over their feet and have them assist you as much as they can by pushing up from their wheelchair. Transition the patient back into their wheelchair. Make sure that your body remains close to your loved one and reach around their torso to firmly grasp onto their gait belt. Have your loved one lean forward over their feet, and you and your loved one are going to do the work to pivot them back into the wheelchair. Once your loved one is seated, replace the footrests or any arm rests that you removed from the beginning.
Position the wheelchair so it is next to the tub at a slight angle as shown and lock the brakes. Place both of your loved one's feet on the pivot disc and remove the leg and armrest closest to the tub. Have your loved one lean forward into your shoulder, grab a hold of the gate belt, and assist them off the wheelchair and onto the tub platform. Their feet should swivel on the pivot disc as you move them. Have your loved one hold onto the platform as you assist in lifting their legs into the tub one at a time.
When transferring patient from the tub to the wheelchair, first begin with a lateral scoot towards the side of the wheelchair to get them in position for the transfer. Be sure that the wheelchair is locked and in close proximity to the patient for a smooth transfer. If necessary, place your foot in the tub if you feel safe and help guide their legs outside of the tub. Have the patient then lean towards you, grab tight onto their gait belt, and do a squat pivot transfer back into the wheelchair.
Questions? That was awfully quick, and that patient was very easy to transfer.
Yeah, they're helping a lot.
I do have a comment, no question, on the toilet deal. I'm having trouble cleaning myself, so we bought a, it's called it's a bidet, but it's called a smart bidet that cleans you pretty good. So might want to talk about that.
Most patients love a bidet, so yes, those
We
are
have one too.
Yeah.
We have one too.
Unfortunately, we used to keep them in the loan closet, and because of COVID and the fact that we are not able to sanitize them from getting them back from patients and things like that, we are no longer able to provide those. So you can get them on Amazon, you know, those sorts of things. But I would say probably greater than 95% of our patients end up getting a bidet. So yes, you are correct. They are lifesavers when it comes to.
Yeah, the one I bought was from Amazon was, oh, I'm sorry. The one I bought from Amazon was less than $200, and it works good.
Yeah, yeah. Other questions about that transfer?
We had a bidet installed that's hooked up to our water line. And of course, most toilets don't have any type of an electrical outlet close. So there's a problem too. There is you have to have an electric outlet put close to your toilet to have the whole thing function correctly. But it does make a tremendous difference. It makes a huge difference if you have a bidet.
Yeah, that's true. I had an electrician come in and reroute my electricity into the bathroom. So I did have it hooked up to the electric.
You have to have that. I did notice that the young fellow that was doing the lifting into the bathtub looked like an Olympic weightlifter. So, most people don't have the strength. I think that young man had to do that. It's as we go through, we'll probably see in terms of showering or bathing, if you can, it certainly is beneficial to have some type of a roll-in shower,
Correct.
And a chair, that we have a chair that she can sit in, and I can roll her into the shower. So that makes a big difference. Yeah.
Right.
A bathtub situation to us seems very difficult. I don't know.
Yeah, bathtubs, I think Sue would probably agree, are not the best option. We always are liking, rolling into the shower and things like that. Bathtubs can become problematic for patients very quickly. So
yeah.
We're definitely looking at a shower option. So, okay, let's move on to the Hoyer lift. Before we get started with the Hoyer lift, I just want to let you know that we do have Hoyers in the loan closet. Clearly, when you watch this, look at obviously the size of this piece of equipment. Even though this piece of equipment is fantastic for ALS patients when they become dependent, and we would recommend it for everyone, not everybody has the room in their house for a Hoyer lift. So number one, we have to keep that in mind. Number two, I am available to come out and train on Hoyer lift. for people that get these out of our loan closet. But also, if your doctor is ordering them, insurance does cover. You can get insurance to pay for a Hoyer lift. And then if the doctor is ordering this, he can also order for a physical therapist to come out and offer the training as well. So you do not need to feel as though you have to figure this piece of equipment out on your own. We can get a physical therapist out to train you, and also can send me out. So we'll go ahead and watch this.
I just have a comment from Betty Ann. She said, keep in mind your electrical source can be your light on your ceiling in your bathroom. So they could use your light in the bathroom to put the electrical source for the bidet.
Okay,
Can you explain real quickly, you said that on the Hoyer lift, that the insurance would cover. Can you explain that to a little more detail?
go ahead.
Yes. So what has to happen for a Hoyer lift is, there has to be a face-to-face from the physician saying that you meet the qualifications based on Medicare guidelines. And that note would be sent to the company that we would get your Hoyer lift from. As far as what insurance covers, it would be what your insurance covers. Some insurance covers 90% of everything, and then you have to pay the leftover 10%. It would be based on your insurance, so everyone's copay for it could be a little different. But it is certainly a piece of equipment that, based on the diagnosis of ALS, it is definitely covered.
Thank you.
You're welcome.
Begin by scrunching up half of the sling. Roll your loved one towards you and place the scrunched up sling under your loved one. Now, roll your loved one away from you and unroll the sling so that it is fully under them. You may adjust the sling as needed so that it covers them from head to buttock. Bring the Hoyer lift over and position it so that it is directly over your loved one. Make sure to lock the brakes. Attach the loops onto the Hoyer. Next, you will want to cross the leg straps. Note how the straps get looped through each other. This is very important. Attach the leg straps onto the Hoyer as shown. The Hoyer offers multiple loops, so choose the one that best fits your loved one. Make sure the Hoyer handle is locked so that when you try to raise your loved one, it does not continuously fall. You may have to adjust the sling to ensure your loved one's head is supported by the sling. To do this, just grab a hold of the sling and pull upward until it supports their head.
So let me just stop this right here.
Disclaimer.
You are typically not doing that, and the slings that we recommend and that we give for you do cover up to their head. They position this a little low, and this sling I think is a little too small for this guy. But typically you're not going to be getting on the bed like this, like she is with this guy. That sling is already going to cover and cradle the head, so you're not going to have to
Yes.
get on the bed like she is.
Yes.
So.
They're based on height and weight.
And I have a question. In the video, there are two people.
Yes.
I only have one.
Correct.
Only me.
Yeah. There is, obviously, that trial and error where you're learning to put that sling under and get it in the right spot. We all have gone through that. But you will learn where that right place is on that sling very quickly. But most of the slings do cover up and cradle their head appropriately. You should not have to be doing what she's doing, and you can figure it out with one person. It just takes a little extra effort.
Yeah, you can roll them by yourself too. So when the other girl was helping, you just pull them away from you or you push them the other way. So that it's easy to do by one.
Yeah, and they'll show that too, Sue, in this video.
Continue to raise them up until they're completely off the bed. Your loved one should sit comfortably in the sling as shown. Unlock the Hoyer brakes and move them to their desired location. You may swivel your loved one around as needed. Once at your location, relock the Hoyer brakes. If someone else is available, have them hold onto the strap on the back of the sling to further assist your loved one into the chair. To lower them, slowly turn the metal handle located next to the lifting lever.
So I'm going to stop this right here for a couple things. First of all, yeah, it always works better with two people, but that's not always possible, obviously, in the real world of having an extra person. Number two is you're bringing that bar down. You want to make sure that you're not knocking them in the head. We've all done it before, so you have to you have to kind of watch where that bar is. Somebody asked the question of do we have power Hoyers?
Yes, we do. So typically with the ALS,
Can you say that again? It comes with what?
electrical or electric.
Oh, electrical. Okay.
The crank that they're showing here.
Instead of pumping, yeah.
Yeah, so they are available. It is something that you can talk to your clinic team about and let them know, hey, I'd like an electric one. The only caveat to that is insurance will only cover the hydraulic one. So if you want an electric one, because it's a little bit easier, you don't have to crank your arms, it is going to cost you extra. You would have to pay extra for that electrical portion, and depending on your insurance, it's going to be anywhere from $500 to $1,000 out of pocket, because insurance is not going to cover that. And correct me if I'm wrong, most of the Hoyer lifts in the ALS loan closet are the hydraulic crank ones.
Yes, just like these that you see here. So every once in a while we will get an electric one, and they're a hot commodity. But she does look like she has great arm strength, but honestly, it does not take a lot of arm effort to operate that crank. Even though you have a patient that might weigh a lot, that crank really doesn't take a lot of effort to maneuver. So it does take some. I'm not going to tell you it doesn't. And it seemed like she was having a little difficulty moving him. If you look also, she's on carpet.
Yeah.
So depending on what your flooring is in your home changes how easily or how hard it is to move that piece of equipment as well. So you can definitely get a workout if you're moving over carpet as opposed to tile or wood, you know, that sort of thing.
Can you recommend the number of feet that might be required between the bed and say the wall where the lift goes in between? How many, 6, 7, 8 feet or something?
I don't know how long. What would you say?
You know, we never actually have measured that, because you also need to be able to get the Hoyer lift underneath the furniture that you're in. So the bed. So some beds have a bed frame that comes all the way down to the floor or only a few inches off. Sometimes that's not going to be able to go underneath the piece of furniture. But I would say
I'm thinking about next to the wall where the bed is.
Right.
You know, maybe you have a bed and there's a nightstand and then the wall. I mean, how much area do you need to get that in there?
5 feet, I would say 4 or 5 feet.
Yeah.
So you're gonna have the length of those legs. Now
And
those
then
legs
turning.
do move in and out. So like for instance, she has maneuvered those legs wider than the chair that they're putting him in so that she can get that Hoyer right up to the chair. As far as a bed, you need about 6-inch clearance. So the bed needs to be about 6 inches off of the ground so that you can get the legs under the bed. So those people that have bed frames that actually sit on the floor, obviously you have nowhere to put those legs, and the Hoyer needs to go under the bed to be able to put the patient in the bed. So there could be issues with that as well.
Also, if they have a nightstand, what you were asking before too, sometimes you have to turn it the other way because you do need to get it closer to the middle of their body. So if there's a long nightstand, often if you just turn it sideways, if there's still enough room, or else use a smaller one.
Yeah, thank you.
Hey guys, I just measured the one we have.
Yeah.
You're right, 4 to 5 feet is about normal. You can get away with a little less if you start early on the bed and slide part of it underneath. But
Okay. Thank you.
Thank you.
Undo the loops and the transfer is now complete. Reloop the straps when you are ready to transfer your loved one back to bed. Make sure you loop the leg straps through each other as you did before. Ensure the metal handle is locked and begin lifting your loved one. Unlock the brakes and transport your loved one back to bed.
You don't need too much. It's turn it though. Feel it's okay.
Once your loved one is directly over the bed, lock the brakes on the Hoyer. Slowly turn the metal handle to lower your loved one into the bed. Undo all of the straps on the sling, and the transfer is now complete.
So something else I just want to bring up on this is the fact that if you're transferring them to go to the bathroom, obviously when you saw it's a split leg sling for a reason, so their bottom can be exposed. So clearly you would want, pants down if you're going to transfer them to the bathroom. Even if you're transferring to, let's say, a shower chair and you're going into the shower, you can leave that sling behind them. There are lots of slings that are made of mesh. They're meant to get wet and air dry. So you don't have to keep thinking about, oh, do I have to take this out from underneath them and put it back under them again? You just leave it there. The only time that you need to be really thinking about taking that away is, let's say, if you're transferring them into their power wheelchair and they're going to be in the power wheelchair all day. You wouldn't want them to sit on that sling all day long. But other than that, it's okay to leave that sling where it's at for that time that you're transferring, if it's to the shower chair for a shower or to the commode, that sort of thing.
Vic, did that help answer your question?
The other thing that's important to remind you about is that you can put the sling on in a power chair or in the recliner. You don't need to get it underneath them. So if you can just lean them a little bit forward and scoot with your hands behind their back, it doesn't cover their buttock. It just goes to the base of their spine. So you don't, like Janie said, you do not want to leave them sitting on a sling. You want to take it off when they're there, and you can easily get them in it again, even if they're sitting.
Okay, let's move on. Oh, maybe that was it. Yay, that was it. Cancel, cancel, stop, cancel, cancel, stop. Okay. Okay. Does anybody have questions in general about what you saw there? Okay, if you do, go ahead and put them in the chat box. Now we're going to move to some range of motion exercises. Sue has some exercises that we typically will show you during our Caregiver Skills Day. We usually give out a packet of information, and in the packet are these exercises. So if any of you have gone to your ALS clinics and they talk about range of motion, even if you have a physical therapist that has been ordered at home or you're going to outpatient physical therapy, it is vitally important for ALS patients to have range of motion done, especially to those joints that they cannot move themselves. And unfortunately, insurance does not cover a physical therapist to come out every day and do it. So the physical therapist comes out and says, here you go, I've trained the caregiver, now the caregiver needs to do it. So it's pretty important that the caregiver does do this every day. When we talk about pain with ALS, the disease doesn't typically cause pain. The pain that's involved with the disease is typically from frozen joints and that lack of movement with those joints and what the pain that comes with that. So we really want to keep every joint as mobile as we can. I don't know if you can really see very well or not, but if Amanda can't move her arm anymore, then there's no point in, she's not going to have any movement. If she's not using that arm, I need to move it. I need to rotate it so that she doesn't get frozen shoulder. If she's not able to lift her arms up or move them, then she's getting nothing here. So it's very important for us to keep thinking about moving all of those joints. So I'm going to turn it over to Sue here. She's going to give you some, show some exercises on the screen and kind of walk you through what those range of motion exercises are. Oh, Sue, you're on mute. There you go.
I'm going to reiterate the same thing. It's very important to do the joints that you maybe cannot move yourself, but it is also very important that while you still can move them, that you keep moving through that range of motion as much as possible, because you are going to, when you do lose some strength, you'll have that mobility to be able to go there. Janie, are you doing, oh, now I can do share now?
Yes.
Okay. Okay, so this is just a little handout that we have given when we go to the meetings. And this first page really basically goes over what Janie just covered. The definition for range of motion is just passive, meaning that you can't do it yourself, so you need someone to help you. Their active assistive kind of range of motion are things that you could do on your own when you're weaker, but you can't complete the whole range of motion. And sometimes that means when you can't lift one arm up, but you could lift the other arm up, you can use your own arm to lift the weaker one over your head. We also know that we want to remind you that we want to preserve range of motion, but we don't want to force range of motion. So if it is very painful for you, if you've got a predisposed shoulder injury or arthritis in a knee, and your caregiver is trying to move your knee or your shoulder, you want to keep that motion within the amount of range that you have that is not painful. Sometimes we'll say we want you to tweak the edge of it, meaning you want to get to the part where you can do pretty comfortably, but we don't want to cause pain. So that's the other thing to remember. The other problem is that not only with especially shoulders, we're really prone to frozen shoulders is what they call it when you kind of can't move it anymore. And that is going to affect your ability even to get dressed and to do bathing and things like that. So we really want you to be moving those limbs. This is something that can be hard for a caregiver to do, especially back to the gentleman if the patient is very large and the caregiver is very small. Sometimes it's difficult, but ideally we want you to perform this maybe when they're lying down, or if they have a power chair when they're stretched out all the way, so that you can use then gravity. If I'm sitting up and I'm lifting your arm up in the air, it's going to be more work than if you're lying down and I lift your arm up in the air. Gravity is my friend at the end of your range. So we prefer to have you do it in lying down. The first part is about the range of motion, is about the legs. And again, if you really are having difficulty, this is a time when we really do love to have home health come in or have an outpatient physical therapy visit so we can teach you how to hold the limb, because it seems like it's really easy to lift up someone's arm or leg, but if you're not holding it correctly, you can be working a lot harder. Just like the transfers, we want to use good body mechanics so that you don't injure yourself to move them. And you want to go really slowly. You're not going to go really fast. The first one on the left is just doing basically the knee. You're lifting that knee and hip up. You're putting you lift it from you put their heel into your hand, and then the other hand, you can't see it very well on the first one, is underneath the thigh, the distal part of the thigh, so the bottom, kind of where the knee is. And you're just going to go up and down. Again, you want to be in a good position, so you don't want to have to bend over to do that. If you can't, if the bed is too low and you can't do it without bending over, you can even sit down or get a stool so you can sit on, so it gives you a little bit of assistance. And usually we'll say about 10 times on each motion. So the first one, she's bringing the leg up, and then she's bringing the leg back down again, and just going nice and slowly. And you want to be sure on this one that you don't turn the leg in and out on this one, because you want that kneecap pointing straight up. So it's just hip and knee flexion. The second one, however, you do bring it up to 90 degrees and you're just holding it there. And then you're going to turn the leg in and out. So the foot kind of goes in and out like a windshield wiper, and it's just going back and forth. And again, slowly to the edge of the range of motion. The motion that she's doing right there, that with the foot out, is actually the one that kind of hurts for a lot of people. So you really just go to the edge of that and then go back again, and to the edge of it and go back again. The next one down, you're doing, you're bringing the leg in and out, and it looks like she's holding the foot, I don't know, with her hand. Basically, I would put one hand under the bottom of the thigh, like where just above the knee, and the other one I would put above the ankle. So you're just kind of using your body to go in and out. And you probably want to stand with like kind of in a staggered stance, like a one foot in front of the other one, and just shift your weight up and in and out so that you're not using a lot of body motion too. Again, I don't want you to be bending forward and backward, or then that might make the caregiver's back sore too. So we're always looking at our body mechanics and being careful not to hurt ourselves. And if you're having pain doing it, then you should talk to one of us and see if we could give you another way to do it, because there's usually modifications that could be done. And these lower extremities leg exercises are really important, especially for someone that has a lot of muscle tone or spasticity. If they've got increased tone, these just really are helpful to loosen up those joints. And when the joints move, it actually lubricates. There's a little bit of synovial fluid that disperses, which can help them sleep better. So sometimes we'll say, you know, if you're having trouble sleeping, maybe this would be a good time to do them before you go to bed. The lumbar rotation on the right, that one you would bend their knees up, and sometimes, you know, if they can't hold their knees up themselves, that's kind of a hard one. You want to get them so you could get the feet flat enough that you can turn their thighs in and out, again, like that windshield wiper motion. But if they can't keep their feet in place, sometimes you need one hand to kind of hold their feet still, and then you move the knees with the other one. Again, if they can't keep their knees together, you want to be careful that one doesn't fall out, and then you want to keep them together too. So it's a little bit awkward, and again, you can even use the gait belt to kind of put around their thighs if that is a good exercise for them. Some of our patients have back pain, and this really feels good just to move through that lower spine, just to get some motion in there if you can't do it yourself. But always, again, only if it's not painful, and only if you can maintain the position without hurting yourself.
Sue, there's a question.
Okay.
They want to know if it's better for repetition or timed exercise.
Usually we say about 10 repetitions is easier. Again, this is going to depend on the patient. If the whole period of doing the exercises is way too much and too exhausting for you or for the patient, then you can break it up into different sessions. Maybe do 15 minutes, maybe do just the lower body one time and the upper body. But we do need that repetition of motion to get that lubrication and those joints going, and for that stretch effect. So it is important to probably try to go for 10 repetitions of each one. Back to the ankle. The first one, they're just bringing the ankle in and out, and again, supporting again the lower leg. And this one, your leg would probably be relaxed, and that would be okay. The second one on the right there with the toe flexion and extension is really something that feels great for our ALS patients, because if you can't move your toes, you get lots of people get those lower extremity cramps, and these really feel good going through. It stretches. The toe flexors are the ones that are your arch of your foot. And when you can stretch through and extend those toes back and bend them, it really helps with some of that spasming in the foot and the lower leg, because that those muscles obviously are in that lower leg. And specifically for those muscles in the back of the leg is that next one, which is the heel cord stretch. And this one is really easy to do, and especially for people with that spasticity in their legs, it feels really good to stretch out that calf muscle. And all you do is you cup your hand right into their heel and put their foot against your thigh or against your forearm, and then you just lean forward just a little bit of weight, and they feel a really nice stretch behind their calf and behind their ankle. This is the one that I would probably hold a little bit longer. I might hold this one for about 30 seconds or so, and you don't have to do as many of a stretching activity. You don't have to do as many repetitions. You want to really get a nice stretch through there. So that's the one that, and the hamstring that I would probably hold time-wise. I would probably hold that one longer. The next one, again, you're pushing the foot down, and you're just stretching out the top of the lower leg. And that muscle is one that gets really weak frequently. People that have what we call a foot drop, they can't pick their foot up anymore when they're walking. If they can't get that toe up, this muscle is the one that tires. And so it feels really good to kind of stretch it out a little bit. And again, this one, this one I wouldn't hold. I would just go back and forth. I would do the 10 repetitions for this one. Then that hamstring stretch is just really a really great one for people that have lower extremity tension or spasming, or if you just can't move it yourself, you would put your hand again, the one hand behind the knee I would probably put the other hand again behind the ankle more than on top of the foot. and then you get a little better ability to lift it up. If it's even too hard, sometimes you can put it on your shoulder, and a caregiver could or a home health nurse or home health physical therapist could teach you how to do that too, just to kind of give them a little stretch through there. But those muscles go all the way to the back of your buttock and insert in that pelvis. So sometimes even our back patients have, this feels really good for them. If, however, this is the one that if you get more back pain when you do this one, then you should not do it, because we do stretch that nerve that runs to our lower spine. So again, always you're listening to your patient, their body. If they can't talk, or if they're not able to talk anymore, look at their face. If they look like if they're crunching their eyes, especially now with our masks, we can't even see sometimes. If you see their eyes wrinkle up, maybe it's too much. Maybe it's too much pain, or just be sure to keep asking your loved one if it hurts or if you can keep going. And often afterwards, most of our patients will say they feel better afterwards. After they've done this stretching, they just feel so much better. So the first few repetitions, maybe be a little more gentle, and then if they're doing okay, you can give it a little more pressure on the rest of them. The next part is on arms. And again, Janie mentioned the shoulders are one that we really get a lot of issues with. This lady on the first one is holding the arm in the air, and then she's bending the elbow and straightening the elbow. There's really no need for you to hold the arm up for that. You can do it even with their arm on the bed, so it saves you some energy. You really just want to be sure that you get all the way to bent and all the way to straight. And that one is just, simply bending and flexing through there. The next one, however, is the shoulder one is probably the most crucial. And this one, again, if you are getting weak, but your other arm is good, this one, you can even just hold your other hand. And when you hold that hand, you can lift the other arm up by yourself, and lying down, that works really well. But again, if you're lying down, this last half of the range from where she's about right now towards the pillow, that part is going to be much easier to do in lying down, because gravity again is helping you a little bit. And then you're not going to get that pinching in the front of your shoulder when you lift it up. Sometimes we pinch into our shoulder blade. When we lay down, our arm is going to fall back in, our arm bone will fall back into that socket, and we won't get as much pinching. So this one is really important to do lying down. And I usually tell people, even if they have a power chair and you're even feeling great, I really like this stretch to do, because if you even are in your chair and you lift both arms back, and you can lift your arms back, it also stretches out your chest and your chest wall, which is going to help us keep our airway open a little bit and just keep us from falling forward. What happens when we get weaker as we start to hunch forward, which causes more trouble with breathing, more trouble with swallowing. So we really need to stretch out this front of your chest to keep you back there, so you can not just shoulder pain, but just better overall cardiovascular condition as well. The rotation one is just like the hip, the same kind of a thing. You're going to put that arm out into a position of comfort. She's got it at 90 degrees, so it's 90 degrees from the chest wall. It's way up there. And then she's just doing this, again, this kind of windshield wiper thing that you're going up and back. If you have a bad shoulder, sometimes you can't quite get it to 90. So it's okay to have it down at 45 degrees and do it that way too. Even though the angle would be a little different, you'd kind of go to your tummy and kind of up, and to your belly button and up, rather than all the way up there and doing it. That's okay. And it is really, again, one that you want to listen to their pain. If it's really painful, the other thing to do would be to put a pillow under their forearm here, because if it's up a little bit away from the bed, up, and she's lifting it up, but if you put a pillow under their upper arm there, the angle isn't quite as bad at the shoulder for hurting. So that would be a way to modify that. The next two, again, are kind of going back to that, actually the one on the left, the horizontal shoulder abduction, again, what they're doing is they're stretching through here. He's sitting up, but again, I really think this lying down position is good because it's going to open up that chest wall. And then it also does give you that range of motion of the shoulder. So even if you can do it yourself, often I'll tell people, if you're in a chair, just kind of go back and try to really stretch it all the way back there. Even before, if you're still able to do it, it's still an important one. We have so many of our patients right now are, because of this COVID-19, we're all sitting at a computer hunched over here, and everybody could benefit from stretching out those pectoral muscles in your chest wall. So that's another one I would really do. So if they could do this themselves, that's great. The second one on the right is that she's pulling her own arm here. If they can't do it themselves, then you're going to hold again to put one hand on their wrist and the other one under the arm, and you're going to pull it out and in. Again, we're just stretching out all those different muscles that go around our shoulder. Our shoulder doesn't have anything other than muscles, and we've all heard of rotator cuff injuries, but that's what holds that arm in there. So if they get all tight, it can get really painful. And so that's why the shoulder's so vulnerable to get frozen, is because it has so many motions of movement. It goes so many different ways. So we don't want to forget one. So one of them would be also this motion of in and back. And then the next page is going overhead. And again, this gentleman is sitting. He can do it himself. But if you just think about your head weighs about like 8 to 10 pounds. So sometimes if we're already scrunched up and we're weak in our upper back, our head comes forward a little bit. And then when we turn our head, it's painful. Most of us have some arthritis in our body. And so if you would lie down again and do this in lying, your head is going to be supported on your pillow, and you can maybe get a little more stretch to the side. So this is, again, why I really like you to do these stretches at night or in the morning or sometime when you're lying, because you're going to get a little more range of motion and a little less discomfort. The sitting one, the same thing. You can do this if your neck moves well. It's really important. Again, those muscles come all the way down to your shoulder, so it can kind of give you a little stretch this way. But if you're lying down, you can do that lateral flexion even against your pillow. Just help them bring the head this way and bring the head that way, and you can passively help your loved one to get that range of motion. And then the distal, the end of our upper extremity, obviously, is our hands. For our patients that have lost that function, again, just like our feet, it's going to feel better. If we've got a lot of muscle tension, we'll get spasming, and the more we stay stretched out, the less often that is a problem. It might not take it away. You may need other things too, but we know that if we have that capability of keeping everything nice and straight, that will help. So you can combine kind of when you bend your hand down, you actually get the tendon action is that your fingers will make a fist, and that is okay to do. So the caregiver can bend their hand down and kind of curl it into a little bit of a fist, and then bend the wrist back and then straighten those fingers out. Because again, just like our foot, the muscles that do wrist flexion and extension are in our forearms, and that's kind of where we often get some spasming and some tension in those muscles if we can't move them ourselves. So if you're bending your wrist down, then you're going to be curling your fingers in, and when you go back, you're going to be stretching them out. And these again, always, like I said before, you've got to be sure that you're comfortable doing that. Again, we don't want to go into pain. So if they can't get those fingers extended when you do wrist extension, and they just stay flexed because they just can't tolerate it, then they can't tolerate it. Then we'll work on just having you push the fingers straight in either this position or just laying flat. And then the thumb, again, we have a, often some proximal weakness or some distal weakness in those thumb muscles. And we want to just kind of move them through and back and through and back. Our occupational therapist has another handout that's called like the 6-pack. So if you only have finger and hand difficulties, if that's really, but you can still move them yourself, there's a whole series of exercises that we can teach you where you're doing individual joints. And it's not to make you stronger, it's purely to keep those joints moving for as long as possible. And it feels better, and it kind of keeps some of that coordination back. So if you do go to ALS Clinic, when you go there, if your fingers are seeming like you're having more and more trouble, talk to your OT or your PT, and they can give you a series of exercises specifically for the hands. This on this sheet is pretty generalized. And again, it's passive, so they're not able to do it. But just, I want you to know that you can still do things with your hands on your own, and you should always preserve, kind of keep moving through all of those joints. If you're capable of doing it now by yourself, keep doing it. And then lastly, this one doesn't have it in there, but also we often will go through back up to the shoulder there. If you've got some strength in your hands and some grip, often we'll give you a pulley, an over-the-door pulley that you can pull with one hand and stretch the other one up. And again, we get multiple things going on then. You get some stretching through your trunk and your pecs, and you get that shoulder range of motion by yourself. So if that's something that's your shoulders are getting weaker, we almost always recommend that you probably get an over-the-door pulley that you could do for a little while on yourself. That's kind of a lot of information in 1 minute. Usually we go over, we have you do each one of these, and then what we do is we correct your positioning of your hand and kind of help you with your body mechanics. So I know this is not ideal. The main thing is though, you'll have these sheets and you can kind of look at them. If someone's having a particular body part that's really painful, you could ask for a physical therapy visit, or you could talk to your ALS PT or OT at clinic, PT or OT, and they might be able to show you a little bit of a modification when you go to the clinic as well.
Awesome, thank you, Sue. Does anybody have any questions for her? Okay, Sue, if you could make me the presenter again, that would be awesome.
How do I do that?
You should be able to right click on me and it'll say, like in my box, you should say, make me the presenter. Here, we can do it. Oh, maybe I can do it myself.
Did I do it?
No, I did it, but it's okay. Okay, so now we're kind of at this crossroad right now of having a couple more things that we could present. We want to open it up right now for Amanda and I for any like general nursing questions or caregiving questions that you have, just in general. Are there things that you are dealing with right now that are problematic at home? Things like that that you want to talk about? If you can just, Amy? Okay, go ahead.
Yeah, I do. So in addition to the ALS, he does have some cognitive impairment as a result. Frontal temporal lobe, I think is what they call it. So he can be somewhat belligerent. So this is when I talked about he didn't want to use the machine to help him breathe. He was, adamant about it. And sometimes I try to get him to do exercises, and he's like, I don't need that. I don't need that. How do you convince somebody who doesn't really understand, He knows he has ALS. He knows his arms don't really work, but he does not really understand the future and where it's going to go. So, you know, when I wanted to have the shower remodeled so I could have a roll in, you know, it's like, oh no, I don't need that. You know, and it's like, you know, when he says, oh, I never fall. Well, no, not yet. How do you convince somebody that things are going to get worse?
You want to? You want? We'll work on it together. So, as far as, you know, him resisting, like the, you know, BiPAP or the range of motion, sometimes it's just addressing it, you know, in the morning. Hey, let's do some, you know, range of motion. Let's move those arms. If he says no, readdress it in the day. Don't make a big stink about it, because if you say, no, we got to do this, they can become a little bit more resistant to it. Well, why are you telling me what to do? So try readdressing it later in the day. You know, okay, let's go do this, and change their mind, and then, you know, readdress it again.
I also think that a big part of it is just saying that, you know, I am trying to do these things to keep both of us safe. So not only for him so that he doesn't fall, but for you. And lots of times when I've had patients in the past that, let's say they've even been resistant to use a walker, one of the things that I might say to them is, but what if you fall? Let's just what if for a minute. What if you fall and you break a wrist or you break an ankle and you're in a cast for 6 or 8 weeks? That's going to be much more problematic for you down the road than if we could give you something that would be useful to prevent that from happening in the future. So we're trying to prevent that bad thing right now. I can give you the classic case, an example of a client who lived by herself, and she very much wanted to remain independent and that sort of stuff. And she used a walker, and she was dining alone at her dining room table, and she got up from the dining room table to walk away, and she fell and she broke her wrist. And she immediately had to have her sister move in with her because she couldn't put on her clothes anymore or bathe herself and things like that. She was right-handed and she broke the right wrist. And so, you know, by being a little stubborn and I'm just going to go over here to the kitchen, I don't need that walker, she put herself in a very inconvenient situation and had to rely on a sister that she didn't really want to rely on for 6 to 8 weeks until that cast came off. And so I kind of give that example kind of thing, like I want to keep you as independent and the ability to do things as long as you can. And these are the ways that we can keep that. I don't want to have to necessarily get a caregiver in here to, you know, so even though he's having some cognitive difficulties, I would kind of put it in the way. We want to try to keep you independent as long as we can, and keep you able to do things independently as long as you can.
Yeah, that's
Can I also say, you know, if there's cognitive issues, they might not be able to understand it. So then you need to just mix it into your day. So like when they bathe, maybe do lotion and put the lotion on it and do it when you're doing something else. Or when you're putting their shirt on, maybe lift their arm up 5 times then. Or when they're standing up or getting their legs in, then you could stretch or you could stretch. I mean, you don't have to say we're doing range of motion, but just try to, if you change their position at any time, incorporate one of those into it.
I'm kind of a hard-headed guy myself, and that's the thing my wife tells me I'm doing. She's doing it for her also. So she's convincing me that, you know, it's for her also. So that may be something you can tell him. It's for your benefit also, like your bath and your shower. You know, you're doing it for you. So, and it's helped me and helped my wife. So maybe that'd be it.
My husband also has frontal temporal lobe dementia, and I was really at my wit's end. Personality change. He was sundowning. He was just extremely difficult. We've had a couple of serious falls where he's had stitches in his head, which doesn't help with the cognitive. About 6 weeks ago, we saw our GP, even though we go to the Mayo, our GP changed his medication, his antidepressant medication, because he's also depressed. And it was just, literally, almost within a week, he was much calmer, and I can reason with him more, and it's not always the case. And when I find I can't, or he tells me I'm lecturing him, I just walk away from it. We also have the situation where he refuses to use his walker, and he wants to go in the kitchen and get ice cream, say, and he'll leave the freezer door open, and he just keeps saying, if you want something, tell me, I'll get it. Oh no, I can't bother you all the time. You have to, relax. But so we try to find our middle ground there. But it's worth talking about some antidepressant because the quality of his life is much better. I see him engaging more with people to the extent that we, see people. And I do have caregivers now. I've increased that, and our caregivers are great with him, but he seems to respond to them really well. So I also have, it's actually one person, I have her do the things that he doesn't want me doing. So, just some firsthand experience.
Yeah, Donna, I think you and Amy are in a very, you're in a different situation. So when we're talking about FTD, that frontotemporal dementia, sometimes you can't reason with them. And so I think in that case, it is very beneficial to talk to your neurologist about medications, because sometimes that's the only way to kind of level them out. To help that situation. Now, most times, if we're talking about cases and numbers, 10% of patients have FTD. So we're not talking about a high percentage of those patients. So the rest of you who are having it, people like Charles, who called himself out, are those stubborn patients that just want to be as independent as possible. And I totally understand that as well. I want to keep ALS patients as independent and as highly functioning as they can be, as long as they can be. That's why I want to have them working with their caregiver, giving them equipment that they can use to keep them independent, rather than a fall and then a break of a leg or a wrist or whatever, and then it's now I'm really upset because stubborn me went to go get the ice cream and now I fell and I have this cumbersome cast on. So I think it's kind of just reasoning a little bit. Sometimes caregivers, which are typically spouses, want to do everything they can for that patient, and the patient's like, wait a minute, I can do some things myself. Let me do them myself. So there's that fine line too between talking to the caregiver and saying, Charlie wants to give, he wants to fold a load of clothes. It might take you 5 minutes and it might take him 20 minutes, but let him take the 20 minutes to do it if he wants to do it, or whatever. Charlie's like, no way, I don't want to fold clothes. Anyhow, it's just that give and take. You have to talk to each other, and communication is key on what I can do and what I can't do. And also, I stress to patients over and over again, we, meaning the clinic team and your clinic providers, are always looking at what way can we conserve your energy the most. So if you are very stubborn and you are saying, I want to do X, this thing, but we realize that X makes you out of commission the rest of the day, then we're going to tell you, we don't want you to do X anymore. We want somebody else to do it for you. But if that little thing that you do gives you joy and you're okay with, hey, I really enjoy, planting flowers and I'm going to be in my garden for an hour, but then I have to go in and I sit down for 2 hours. If that gives you that much joy that you're willing to sacrifice that 2 hours, okay, there has to be some give and take there. So it's opening those lines of communication between you and the caregiver, what you can do, what you want to do, and what you're willing to give away, but then also the caregiver letting that person do it, because early on in the process, you're like, let me do everything. Everything's great. And then as the disease progresses, you're like, wait a minute, I'm doing everything and I'm exhausted. So you need to realize too that you cannot let your energy stores run out being the caregiver. Let them do some things that they still want or can do, so that you're still not wearing yourself out either. And then we had
I just wanted to mention that I don't know if this caregiver's guide is still available. Huge manual.
Oh. Okay.
If either the patient or the caregiver read this, it will really bring home the message of what you're confronted with in the future. And there's a lot of great information. Is that book still available, or is manual? It's huge.
I don't actually recognize that book. Did you get it from us?
Well, it came from the, I'll turn the back here.
The muscular dystrophy.
Oh, it's from the MDA office.
MDA office, right. And it has a massive amount of very good information that really brings home what you're going to be confronted with ALS. And I think it's very good for both the caregiver and the patient to read it so that they understand what the future holds.
Yes, I agree. I believe you can get that book still off of the MDA website.
That's probably so. Yeah, it's very, very good to read. Yeah.
Thank you. We have a question. My husband still walks with a rollator, not good, but not a lot. But his feet swell every night and uses compression socks. He takes them off and his feet are still very swollen. I massage, use ice, stretch. What else can help? So the question that I would ask you is, are his feet dangling all day, or are we elevating them when he's sitting down? And, if he has a power wheelchair, elevating those legs, or putting him in a recliner to where his legs are up during the day. That can help with the swelling throughout the day.
So swelling is a byproduct of gravity. So if we're in a chair all day, in the power chair, in a wheelchair, sitting in a recliner, we're going to have gravity take over and you're going to have swelling in your legs. If you've been asked to wear compression stockings, number one, you do not wear them at night. So it's good to bring take those off. They will raise your blood pressure if you wear them at night. So we always want you to take those off. But typically when your feet are at the same level as your heart, so when you're lying down, those feet should be at the same level as your heart. That swelling should go down. So in the morning, first thing, there should be no swelling. If there is swelling first thing in the morning, that is something to discuss with your doctor. That may be a separate issue that has nothing to do with ALS.
Yes, they are swollen when he wakes up in the morning even. And when I massage him, it's like an edema. You can feel like you put your thumb into it and it's got that pressure there.
Yep. Then I think that's something that should be addressed with the neurologist for sure. There may be other issues going on, or they may want to give him like a diuretic, which is a water pill, something to pull some of that fluid off.
Yeah.
He should not still have
The
swelling in the morning. Typically, ALS patients with their normal swelling that they get will not have swelling in the morning. So if he's still got that, you know, I don't know what his history is, but just off the top of my head, you know, there could be some sort of cardiac issue or something like that that is disrupting, you know, the normal homeostasis, that sort of thing, causing him to have that swelling in the morning when he shouldn't.
Thank you. I just wanted to make sure it wasn't something that came with the disease, and that's something I needed to deal with.
Yeah, no.
Thank you.
Yep.
Any other questions?
Well, I've just asked my lovely wife, Dagmar, if her manual, Align, Lengthen, and Strengthen,
Yes, yes.
for which you probably have seen and read. I don't know if everyone has seen it, but it is available online. It is available online if they want it. And it's free. Yeah, it's free, of course.
What was it again? I'm sorry, I missed it.
Well, it's called Align, Lengthen, and Strengthen Your Resilience.
Ron, can you write it in the chat box for people if they want that?
Oh, now you're getting technical. Dagmar could. Where did I do that? Okay, she said we'll try.
Dagmar does lots of writing on ALS, and she has a very good perspective on ALS. She is has lots of good advice, and I've read lots of things from Dagmar. So yes, she is a very good source of information for you. So yeah, if you guys can figure that out and put it into the chat, that might help some people that might want her.
Amy Frank will send it out, she said.
Okay, that sounds good. That sounds good. Yes, she can send it with everything.
Hey, I have the link for the caregiver's manual too, if anybody wants it. That's online too.
Okay, that's awesome.
Where do I
Great.
put it? What
Can you
do I
put it in
do?
the chat box, Dave?
Chat box?
Yeah.
All I
There
gotta do
should
is
be a little
figure it out.
icon that looks like a
Thinking bubble
yeah, like a bubble.
may have some red numbers next to it if you haven't been in it.
No, I'm looking.
Top right of the screen.
Yeah, the
Yeah.
top right of your screen.
Here,
You see the cartoons.
get it?
What's that?
So we were going to go over some emergency preparedness, and I have gone over it in before in support groups, so this may be slightly redundant, but I do want to just quickly
Thank you.
let you guys know that lots of times we also talk about having a to-go bag. So that is a bag that if there was an internal or external disaster, so fire, Lord knows we have that going on in our state right now. What if there's a power outage? Clearly that is a possibility right now. It's been on the news about, you know, the fires causing the potential of disruption to power, things like that. So what we suggest for ALS patients is a few things. If you have equipment, first of all, that, not like a walker, but equipment that requires somebody to learn how to use, to write down how to use it, maybe on an index card, and attach it to that piece of equipment. So for instance, a BiPAP machine, a cough assist, a suction, a power wheelchair. You know, how do I turn it on? Where do I plug it in? That sort of thing. If you are not able to speak, for sure, but let's just say, you know, you're fatigued or you can't get it all out or whatever, and attach that to the piece of equipment, so that we know how to use it if somebody else needs to use that, if you're caregiver and you get separated for any for some reason. Additionally, if you have that equipment, there should be some sort of ID number on it, serial number, something like that on there. Write that on a card as well and put it in a backpack or a to-go bag. That bag is going to be what you take when there's an emergency and you need to get out of the house right away. Okay, if there's a fire and there's an evacuation, if you have a fire in your own house, you know, those sorts of things. So if let's say you had a BiPAP machine and you have to leave, you don't have time to get the BiPAP, we could then call your provider and say, hey, Apria, I don't have that machine anymore. If you have the serial number, they can figure out what machine you had. They can get you set up with a replacement machine. Likewise, cough assist, suction, that sort of thing. That to-go bag should also include your medication list. It should include maybe 5 to 10 days of medication in case you have to run really quickly. You've got some meds with you. Pharmacies will typically give you an emergency supply. So you could always call CVS or Walgreens or wherever it is that you get them. But we would want you to have that list. And if you do have a few days supply in that bag, it would definitely help. Something like some bottled water, so a few energy bars, things like that if you are still eating and get hungry, that sort of thing. If you have advance directives or a living will, for sure put a copy of that in your to-go bag. Put a copy of your insurance card in there. Put a copy of, in case of emergency, this is who you need to call. Put who your clinic doctor is, your clinic team, and how to get a hold of them. Put some cash in there. Not everybody grabs their wallet or their purse when the house is on fire. You know, but if you have this bag beside the door, it may be something that you can grab. If you are on tube feeds, a syringe, an extra can or two of formula in there. If you are incontinent at all, some briefs, or if you're a man and you use a urinal, you know, an extra urinal in the bag, those sorts of things that you might need if you have to find another alternate place to go if you're leaving quickly. Other things that you should consider doing is just in general, getting a hold of your local fire department. You can call them and let them know that you are an ALS patient and here's my address. They will flag your address in their system so that they know that an ALS patient lives there. You can call them for lift assist. So if you fall and you can't get up, they will come up and get you free of charge. You are not billed for that. They will come out for lift assist 15 times a week if they have to, but they will always do that. So it would be to your advantage to call and make sure that they have you flagged. They also may ask you, like, where in the house is your bedroom, especially if you are dependent and you're wheelchair bound and that sort of thing. If your house is on fire, they want to know what room you're in to get you out. So they may ask you that sort of question. They have something called a Knox, K-N-O-X box. Some places it's free of charge. Some is a nominal fee. But a Knox box is basically like those little boxes that the realtors use when they're showing a house. The fire department has those, and they will put a key in there so that they can enter your home without breaking the door down. And they will keep that Knox box on them and only the fire department has it, so they can enter your home if they need to, if the door is locked. So you can certainly talk to the fire department about that. If you are on any device that requires electricity, the power wheelchair, BiPAP, suction, cough assist, anything like that, both APS and SRP have not only, if you have financial concerns, they can help you with your bill, but they also both have an application that you can fill out. And if power is out, you're at the top of the list to get power restored. So it is to your advantage to fill out that application. I have a whole PowerPoint presentation on this, and Amy will send it out to you guys about this, so you know how to get a hold of SRP and APS about that. So you don't have to write frantically about all of this stuff. But it's to your advantage to get a hold of them as well for that sort of information. Let somebody know, let's just say there is a fire or a flood or whatever. Have a mutual meeting ground. What if there's a fire and your caregiver is at the grocery store? Where is it that you're going to meet? Is it the gas station on the corner? Wherever. You need to have a mutual meeting place, and let someone else know where that place is. So either another family member, a close friend, someone from church, whoever it is, let somebody else know what that is, so that you have a place that multiple people know where that meeting ground is. Can you think of anything else? You covered a lot of it. I'm trying to spew it out in as little time as I can. I know it's been a long day for a lot of you that have been here since the very beginning. So if you have other questions, certainly you can put them in the chat box. You can email me, you can email Amy. You guys know how to get a hold of us at the association. We are more than happy to answer any questions, things like that. I want to be respectful of your time, and I see it is 4 o'clock, so I'm sure many of you are exhausted and maybe hungry and everything else. So, so thank you again, Sue. Thank you so much. Amanda, thank you. Thank you everybody for joining. I hope it helped a little bit clarify things. It's the first time we've ever done this. If we still have coronavirus in the future, we may have to do this again, and I would appreciate any input on other things that you guys would like, maybe some information and training on. If we have to do it virtually in the future, we may, shift gears a little bit and focus on other things. So thank you all.
Thank you so much. This was wonderful.
All right, you're welcome.
I have been here all day.
Thank you very much. I appreciate it.
You're very welcome. Sure. All right, take care, everybody.
Thank you.
Bye-bye.
Appreciate all of it.